Hi, everyone, and welcome. I'm Jen Elder. I'm the director of the Homeless and Housing Resource Center, and we are excited that you're joining us for session 3 of the Trauma-Informed Outreach and Engagement Learning Community. And today's session will be covering making the connection to the homeless response system. Next slide. So we'll start, as we always do, with a quick disclaimer. We are funded by the Substance Abuse and Mental Health Services Administration, but the views and opinions expressed today don't necessarily represent official opinion and perspectives by SAMHSA or HHS. Next slide. We do have our American Sign Language interpretation team and captioning on today's webinar. If you're having any technical difficulties, reach out to us. It might be the easiest to just reach out using the Q&A feature, but you can also email us if you're having difficulties. So next slide, just some quick housekeeping. I know that many of you have joined us before. So with our webinars, the participant lines will be muted and the chat feature is disabled, but we do absolutely welcome your questions using the Q&A feature. The slides are available now on our website if you'd like to download those and follow along. And we'll have the recording available in about 1 week in case you would like to go back and review it, share it with a colleague. That'll be available there for you, along with a link to the evaluation. So our evaluation process today is a little bit different than in previous sessions. It's going to be a little bit shorter, and we'll give you that link at the end of today's webinar. It'll also be available on our website. So with that, I think the next slide, we're excited again to be joined by Jillian and Alicia from Homebase, who've been facilitating this series, and Shelby Ferguson is our guest presenter today. So without further ado, I'll hand it over to Alicia to get us started.
Thank you so much, Jen, and thank you everyone for being here today. We are so excited by all of the interest and participation in this webinar, as well as the past 2 for this series. As Jen mentioned, my name is Alicia Lemer. I work with Homebase. I am joined today by my colleague, Jillian Marchetti, also with Homebase. We are also incredibly grateful to have our guest speaker today, Shelby Ferguson, who is joining us from Contra Costa Health, Housing, and Homeless Services to talk about their incredible work integrating homeless, housing, and behavioral health services. Next slide. So today's presentation is part of the Trauma-Informed Outreach and Engagement Learning Community for serving people with serious mental illness, serious emotional disturbances, substance use disorders, and co-occurring disorders. We are pleased to see so many people joining us from the first 2 sessions. We are really excited because this is a 4-part series where you are learning about best practices in trauma-informed care and person-centered outreach, how to connect people with services and housing, and how to provide behavioral health care assessments in unsheltered environments. As you can see here, we are on session 3 today, making the connection to the homeless response system. We already had 2 great sessions in June on trauma-informed care and best practices for person-centered outreach. Those first 2 sessions really focused on making that initial connection with people experiencing homelessness. And our session today builds on that foundation, and really building on that work that you've done to make that connection with people experiencing homelessness, and then connect them to the homeless response system and other systems of care that are going to meet their needs. Before we jump into our main presentation for today, we'd like to just take a moment and provide a quick recap of some of the information shared and the lessons learned from those first 2 sessions. Really knowing and acknowledging that trauma-informed care and person-centered outreach are really foundational to all of our work. We want to make sure we carry that information forward into this presentation as well. So starting with trauma and trauma-informed care, in our first session, we talked about how we conceptualize trauma around the 3 E's. That is the event that caused physical or psychological harm, the experience, which is how a person responds to and assigns meaning to the event, and the effect, which is the long-lasting adverse outcomes and impacts of trauma on the person. We also talked about how the experience of homelessness itself is traumatic and can exacerbate the effects of other traumatic experiences, such as histories of violence, neglect, abuse, or discrimination. During that first session, we had a fantastic guest speaker, Tiffany Juarez from Battling Minds in San Antonio, Texas, who was also able to speak about her own experience with those core concepts of incorporating trauma-informed care into her work, particularly with people experiencing unsheltered homelessness, and Tiffany was able to emphasize that trauma-informed care is rooted in foundational concepts that people and their individual experiences matter. In our second session, which was focused on person-centered outreach and engagement, we explored the roles of outreach and engagement in building trust with people, getting to know their needs and their goals, and beginning to build that foundation to connect them to resources. And we discussed different ways to approach and really practice person-centered outreach and engagement in our work. As we went through that webinar, really a big emphasis of that was the importance of taking time and building trust, recognizing that person-centered outreach, which necessarily builds on those principles of trauma-informed care that we were just talking about, requires compassion, a focus on each person's strengths and needs, and working from a place of humanity and partnership. We were also joined by a fantastic guest, David Katzenmeyer from People Incorporated Mental Health Services in Minnesota, who was able to provide incredible insights into what applying best practices like peer support and motivational interviewing actually look like when you are conducting outreach and engaging with people experiencing homelessness who have behavioral health needs, and how to make sure that we're doing that in an authentic and meaningful way. As I mentioned when I started the slide, we really just wanted to provide that context, as a recap and a refresher for anyone who has been on the first two sessions, but also for anyone who wasn't able to join us, just because we know these are so foundational to our work moving forward. As for today, our learning objectives are going to be building that foundational knowledge around the homeless response system, including continuums of care and coordinated entry. We are also going to be helping to build that understanding around how to connect people with behavioral health and housing needs to housing and housing related services and other resources through coordinated entry systems. And if you don't know what coordinated entry is, I promise you we are going to delve into that a little later in our session. And then we're also going to identify opportunities for behavioral and other health providers to partner with the homeless assistance systems to better serve people with behavioral health and housing needs. So really looking at that integration of our housing, our health, and our homeless response systems. All right, before we get started, if you've been on one of our first two sessions, this will look familiar to you, but we really want to know who's joining us. Please select which best describes the focus of your work. Is it behavioral health care, physical health care, homeless services, housing, social services, outreach? Or if you feel like those don't quite describe, there's an other option in the poll. Give you just a few more seconds to vote. I think we can share the results. All right, so most people on the line are either part of the homeless services or housing, but we have representation across the board. We have quite a few representatives from behavioral health care, social services, outreach, and a few people representing physical health care. We are incredibly excited to have you joining us today. We really hope that this is a meaningful webinar for you. Next slide. We're going to launch our second poll, which is how much of your work is with people experiencing homelessness. We know that a lot of you are working in homeless services, but this is to get just a little bit more information on, is 100% of your work dedicated? It's most, some, are you just working with a few of your clients who are experiencing homelessness? Give you a few seconds to respond to this one as well. I think we can close this poll, share the results. All right, almost half of people are working 100% dedicated to serving people experiencing homelessness. But we have a lot of people across the continuum of working with most clients, some are a few. Thank you so much for answering these questions. It's really helpful for us to know who's joining us, and especially for today's session, where we want to acknowledge that many of you are probably part of your local homeless response system, while others are working to make that connection. So we know that people are joining us, from different points of connection. We hope that today's session provides everyone, regardless of your current knowledge, understanding, or level of connection with the homeless response system, with some new information to help you best serve your clients experiencing homelessness who may have behavioral health needs, and to make those connections to needed shelter, housing, and services. If this information is more familiar to you, we hope that it may be an informative resource that you can share with other organizations in your community, with newer staff at your organization, or that really just provides some different insights and perspectives onto how you can really make that connection with the focus on serving people with behavioral health needs. So I am going to now get us started on the main topic of today with a brief overview of core concepts in homelessness response. Next slide. So although various types of funding for homeless assistance come from the federal and state governments and local jurisdictions, homelessness response really does happen at the local and community level. So in almost every community across the country, you're going to have a myriad of organizations and agencies that provide a variety of types of assistance to individuals and families who are at risk of or experiencing homelessness. This can look really different depending on what state you're in, what jurisdiction. So you might know some of those local resources that are available, but really we see this as a variety of types of assistance across the country, and there's no single agency or organization that administers all resources and services. It really is going to look unique. Due to limited resources, though, we do know that the vast majority of housing assistance is prioritized for people living on the street, sleeping in vehicles or tents, or staying in emergency shelters. Communities often prioritize housing and intensive supportive services for people experiencing what is called chronic homelessness, which means those that have a disability and have been homeless for more than a year. So the types of assistance provided vary by community. I know that I talked about that a lot on the last slide, but I think it's really important because what is needed in your community is going to look different depending on a number of factors. How many people in your community are experiencing homelessness, in particular unsheltered homelessness, what your geography is. So thinking about rural, urban, suburban areas, and then, also what resources you have available, what the funding sources are that are available to that locality in particular. So we know that what you have available might look different from what other people on the call have available, but in general, the types of assistance that we see in the homeless response system include emergency shelter, temporary or permanent housing, transportation assistance, services to help meet basic necessities like food, water, access to supports, particularly for people who might be residing in unsheltered situations and need protection from the weather. We also see employment, we see financial support that's one-time or ongoing, and then supportive services, which can look like quite a few different things, such as case management, education, employment, and other services, which we often wrap around the client to help them achieve their housing goals. Just a note on this slide, the homeless response system may not be able to provide physical and behavioral health services directly. Some organizations may be able to do that, but a lot of times we see really making connections to other systems, to the health and behavioral health systems, to provide that level of expertise in meeting the needs that we see in our clients. So supportive services does and can include that physical health and behavioral health connection, but sometimes that's not provided within the homeless response system. Sometimes it's through connections, which is why this topic is so important, how we make sure that those resources are integrated. Next slide. So one of the key concepts that we really want to talk about today. And a lot of you may be familiar with this, you may be part of this, but we really wanted to talk about the continuum of care, or the COC, which is an umbrella term for the group of organizations and agencies that collectively coordinate homeless assistance activities and resources in a community. So we want to provide some information and some clarification. It is not a legal entity. It is a coalition of organizations and entities that meet regularly to discuss and plan their community's homelessness response. We also know that each COC designates an entity, which is often a local government agency or a nonprofit, to apply for federal homeless assistance grant funds through the U.S. Department of Housing and Urban Development. You may be familiar with this process. It happens annually. HUD awards homeless assistance grants to COCs through an annual competitive process. This is a pretty big function of the COC, is to help with that process, run the local process based on community priorities, and then determine which organizations should receive funding from HUD and for what purposes. I will say that often the purposes that are prioritized during those local competitions, it's really focused on rental assistance to help people exit homelessness. The primary purpose of a COC, and this is built into that funding as well, is to promote a community-wide commitment to ending homelessness. COC members attend meetings, participate in community-wide planning, and coordinate with each other. While many agencies that participate in a COC do receive HUD funding through that process that we just talked about, not all of them do, and not all receive federal funds, but they still may participate in the COC for a variety of reasons. That could look like increasing the impact of their own work, learning about more of the resources in the community that are available that are going to be able to serve their participants, learning strategies and helping to shape strategies and best practices for responding to homelessness, and building relationships with other leaders and organizations with similar missions and values. So there's a lot of reasons that people may be connected, organizations may be connected to the COC. And if you are not already, there's definitely a lot of benefit that can come from making that connection. Finally, HUD requires COCs to develop certain processes, including a coordinated entry system, which functions to ensure that people who need housing and other supports are connected to local resources in an equitable and coordinated way. My colleague Jillian is going to talk about coordinated entry in a lot more depth in just a moment, but just wanted to highlight that that's another core function. All right, and as you can see on the slide, there are a huge variety and diverse array of stakeholders that often participate in your local continuum of care. You can see that some of the diverse organizations that are represented on the slide include local nonprofits, community stakeholders, representatives from education, employment, physical health, behavioral health, criminal legal systems, and more. So really, this is meant to weave together all of those organizations that may be working with people experiencing homelessness, that may have clients that are experiencing or have experienced homelessness, or are at risk of homelessness. It's really meant to create that comprehensive approach. It's also important to note that people with lived experience are crucial partners and participants in the COC's work. In fact, the COC needs to have a board which is comprised of representatives from local homeless assistance organizations and at least one person with lived experience of homelessness. So this really does, it really does attempt to center people with lived experience in all of this work. And we know that's so important to making sure that the interventions we create are, really appropriate and trauma-informed and client-driven and led. With that, I am going to hand it over to my colleague, Jillian, who's going to talk about coordinated entry.
Thanks so much, Alicia. Hi, everyone. Happy to be here. I'm Jillian Marchetti, And a lot of my work for the last several years has focused on housing and homelessness and healthcare coordination and coordinated entry as well. So I always get really excited to talk about how we can leverage, how different communities can use knowledge about and participation in coordinated entry to help really connect folks who have both healthcare and housing needs to the systems of care that they can be helped with. So really happy to be here. And as Alicia mentioned, coordinated entry is one of the requirements that HUD makes for folks who are receiving funding. So communities have all across the country have set up coordinated entry systems. And so that's one of the reasons we talk about it, obviously, is because it exists in every community, but it's really important to understanding how local homelessness response actually functions. But more importantly for today is not just that context setting we want to provide, but the coordinated entry systems and the processes in place in every community really do offer a lot of different opportunities for not just connecting folks that you're working with, especially if you're outside the COC or outside of the homeless response system. Not only it helps you connect people you're working with to housing resources they might need, but also just offers a lot of different opportunities for cross-system partnerships. So it's a really good conceptually to have a really solid understanding of what coordinated entry actually is. So we can go to the next slide. So essentially what coordinated entry is in brief is it's a process or a system that every COC sets up to make sure that people who are at risk of or experiencing homelessness are prioritized for housing and other resources based on the severity of need, and that people are matched to the resources that are available that are most suitable to meet those needs and their preferences. And then really the primary focus or the primary purpose, of coordinated entry is to allocate what we know are always, relatively limited housing resources as equitably and appropriately as possible. Next slide. So we have 5 key things to know about coordinated entry. There are obviously lots of things to know about coordinated entry, and we'll be diving into some of them over the next several slides. But particularly when we're talking in the context of wanting to help, especially behavioral health and other healthcare providers, knowing how to connect folks they're working with to the homeless response system. So these are some of the 5 things we wanted to make sure people are aware of. That coordinated entry, a system in place is required for HUD funding, as Alicia mentioned. There are 6 key components or phases. There's different ways to think about it that I'll walk through over the course of the several slides ahead. Participation is required for programs that are receiving HUD funding, certain kinds of HUD funding, but it's also open to other organizations as well. And so there are, across different communities, there are organizations that are participating in the coordinated entry system, even if they're not required to do so, but because of their funding sources. There are, as part of coordinated entry system that's required by HUD, there are certain requirements that each community has to meet in setting up and operating their coordinated entry system, but COCs, so communities have a lot of flexibility as well in the way that they design to make sure that it's customized as much as possible to meet the particular needs of the folks in their community and the resources that are available. And then finally, so folks are aware, there is an annual evaluation required for coordinated entry. And so a refinement process is intended to be built in so that communities are monitoring how coordinated entry system is functioning and making adjustments as needed to ensure that it's equitable and serving folks in the most needed ways and is operating in the way that it's intended. So some of the reasons that coordinated entry has been mandated and is a practice that communities have all been setting up over the last several years. There's a few things we wanted to touch on specifically. It really is it has been, I should say, over the last several years, an opportunity for communities to really restructure in an intentional way how housing and services are delivered and who is accessing those services. So really gave an opportunity, and not to say it wasn't a big challenge. It doesn't continue to be a challenge as any system restructuring is, but was a really great opportunity to rethink and reorganize how homeless response systems were operating, and meant to be in a more efficient way, right? So it because it is a coordinated process, and again, we'll go through the phases in a moment, but it was meant to have communities figure out ways to really streamline the access to all the different services. Alicia mentioned there are lots of different kinds of assistance and services, lots of different agencies, many of whom kind of sprang up independently in response to a particular need, like is common in a lot of service delivery systems and safety net services. And so it was meant to make it more efficient for folks who are seeking assistance and help to be able to, in a more streamlined way, access and be connected to services and resources. Equity is obviously a huge piece of it. So you'll see prioritization and standardization are two of the other pieces in here, and those kind of all fit together in a way, essentially ensuring that there is equitable access to, again, what is almost always a limited pool of resources. And a lot of the way that equity is accomplished or is intended to be accomplished is through standardizing the tools and practices so that it is consistent, regardless of where someone shows up in the system, who they're connected to, that there's a standard way to assess folks and prioritize them according to their need, and then connect to resources in that more efficient and equitable way. And of course, a big piece, we've talked about Housing First, I think, on both of the sessions in this learning community so far, but a big piece of coordinated entry, which is connected to that equity piece, of course, is incorporating Housing First into the process overall. Next slide. Looking at some of the benefits of coordinated entry, both intended and then when a coordinated entry system is up and running efficiently and appropriately, this is the idea that, without coordinated entry or in communities that hadn't yet set it up or are still kind of working on setting it up, what you have is multiple different programs, all of which have their own processes for determining eligibility and connecting folks to resources and divvying things up. We had each of those programs could have had their own intake and assessment protocols, and so lots of different processes in place for folks to connect to resources, kind of depending on which programs they connected with. Different eligibility rules, which can often result in either a duplication of services or requiring folks to be assessed and kind of show up to individual programs on their own and tell their needs and their stories over and over. And so that's often the case when you don't have a more coordinated, streamlined process. Because of all of that, there's much more subjectivity, which leaves a lot more room for inequitable or discriminatory practices, unintentionally or not. And all of that amounted to a lot of, or can amount to a lot of just a lack of access to programs, right? Because we're depending on people to be able to navigate a really complicated network of programs that all have their own processes. And so that can really set up a lot of barriers between folks seeking assistance and the resources that exist. And the idea of coordinated entry, of course, is that there is easier, faster, more efficient access to all of the myriad resources and programs that exist in a community. There is a more increased focus on collectively shared goals across the coalition of folks working to support folks who are looking for housing and supportive resources. Ideally, because again, there's this more coordinated, efficient system that is intended to match people according to need to the resources that exist. There can be increased exits overall, like system-wide, to permanent housing, and a flow through the system that can allow for folks again to exit the system to permanent housing, and hopefully an overall reduction of folks who are on waiting lists. And of course, mentioned this before, but a much more equitable access process for services that best fit people's needs, which in turn then is maximizing the limited resources that a community collectively has to help people. Next slide. So the next few slides go through the key, I mentioned at the beginning of this portion of the presentation, these kind of 6 key components or phases of coordinated entry, which is basically entering the coordinated entry system or the homeless response system, being assessed. So people to be assessed for their needs and their strengths and their preferences, and then prioritized according to vulnerability for resources. And then there is a process to match folks to resources as they become available, to refer people to those resources, and ultimately place people in housing or in programs that hold those resources. So if we go to the next slide, just gonna walk through these key components. So for system entry we have here, this is essentially for people who are seeking housing or services. This is how they make contact, right, with the community's homeless response system. And that's usually by interacting with some people refer to as like a front door to the system or a door entryway into the system. So it could be an outreach worker, it could be by calling a hotline like 211, or it could be just showing up at a program, the service provider's site. So basically this is the point at which a person seeking services kind of enters the system of care. Assessment, which is the next piece, is the process through which every individual or family, so every household who has entered the system is assessed. And this is meant to be in a consistent, objective manner. So it's using a process and standardized assessment tools to really get a sense of what folks' needs are, what their strengths are, what resources they're looking for, and what they might be eligible for. And then once that information is collected by the system, every individual or family who has been assessed is then prioritized according to the severity of their needs. I'm realizing that content of that, I need to adjust it. So moving into the sort of latter half of the process, we have matching, which is basically as housing resources become available, the people who have been prioritized and so are at the top of the priority list according to their need are given the choice to accept those resources that have become available as long as they're meeting eligibility requirements. So resources that appear to meet their needs so that they're able to decide whether they would like to accept that resource. When that happens, then a person or a household is referred. So the people who have been matched and have accepted a resource are referred to the program that has that resource in hand, which of course requires coordination and communication between those who made that matching decision, the person or the household that would be housed or connected to that resource, and of course the program providing the resource. And then finally, folks are placed into the program and ultimately into housing, assuming it's a housing resource, which usually entails some level of getting the person or the household, what's often referred to as document ready, and often requires, coordination again of the program participant, the program that has the resource, and other partners that are helping to kind of address various different barriers or challenges that may be in place to housing placement and housing long-term stability. Next slide. So part of the reason that we go over the details or the pieces of that coordinated entry is, like Alicia mentioned, not only for folks who are on this call or maybe watching the recording who don't have the familiarity with coordinated entry because you're not necessarily working in the context of a COC or in that space, but also, again, to provide a resource that can be shared out to folks outside of the COC or people who are maybe newer to the work. But the other big piece of it is to provide context for what I'm about to go over in these final slides of this portion of the session, which is to really highlight where the opportunities are to partner if you're between the systems. So if you're a healthcare provider, behavioral health or primary, or another partner, working in a community outside of the COC, I'm just going to go over some opportunities in the context of coordinated entry that are available that can really offer an inroad to building partnerships and really coordination across systems. So again, sticking with the kind of those phases we went through, starting with system entry, there are different ways that you outside of the COC or outside of the coordinated entry system can leverage coordinated entry to kind of partner. So really important to learn basic eligibility requirements. So as you're working with folks who might have housing needs, having the baseline understanding of who is eligible to receive resources and services through the homeless response system is really important. And knowing where the entry points are, right? If it's outreach teams, if it's, folks have to go connect to a specific provider or a specific site where assessments are done, if it's that hotline or 211. So just knowing what the entry points are can really help, of course, facilitate the connection of folks that you're working with to the homeless response system. And then working either within your own system or your own organization or with the COC in partnership, developing protocols for connecting people that you're working with to that entry point, to those entry points of the coordinated entry system. And organizations outside of the homeless response system can serve as entry points to the system itself. So there are communities where, a healthcare provider, for example, can be an entry point to the coordinated entry system. And so there's even less of a barrier then put up between folks who are seeking services outside the homeless response system to get connected to housing services. Next slide. So here we're looking at opportunities that are related to assessment and prioritization, right? Those next two pieces. So thinking about, you can help review, select, or develop assessment tools working with the coordinated entry system. You can, notify the coordinated entry system of people that you're serving who need to be assessed, right? So not only that's maybe connecting folks to entry points, but you can also there can be protocols developed in your community to have an actual process in place for if you're working with someone and you know that they should be assessed via the coordinated entry system, that there's some process developed in place. Folks outside or organizations outside, including healthcare providers, can actually administer assessments, working with your COC to set that up, to have trained folks who are assessing folks. Two pieces we really want to focus on with respect to prioritization that are really critical for health providers is working with your coordinated entry system or COC to make sure that critical health considerations are factored into their prioritization scheme, right? So we mentioned that every coordinated entry system has to set up a way to prioritize folks for resources, right? So what factors are considered? How do you basically define as a community who is the most vulnerable and therefore should be most highly prioritized for resources? And so making sure that you're part of those conversations, even if there's an existing scheme, there can be adjustments on an ongoing basis. And so making sure you understand what the prioritization scheme is in your coordinated entry system, and thinking about how maybe some health considerations that aren't included in that should be, making sure that those can get incorporated or embedded. So having those conversations and being involved in that planning is really a critical aspect of this. And then finally, one last thing on that previous slide is you can also participate in prioritization discussions or case conferences to, again, kind of explain how and when specific health conditions should result in individuals being prioritized more highly than maybe the standard protocols would suggest. Next slide. And then finally, looking at matching, referral, placement, right? So those final three, and again, opportunities to coordinate and partner. Again, in some communities, there are case conferences that are part of the matching process, right? So when resources become available as part of the process to decide who gets referred to those, there might be case conferencing involved. And so again, that's another opportunity for behavioral health or other healthcare providers or other partners to participate, to increase the likelihood that those matches are going to be appropriate and successful, and considering all the different factors that are relevant there. And also helping folks that you're working with, so helping people really understand what their options are and how each of those might impact their healthcare access and outcomes. So when people are deciding, whether to accept a particular resource, helping think through the different options, especially if you have a good relationship with them. Other opportunities are, offering support to housing providers. So offering, healthcare or other services that the COC is in a position to provide folks. So kind of partnering on that piece to make sure that, to increase the likelihood that folks who have been referred and accepted housing placements are successful in that housing. And then also other opportunities are just helping people to procure the necessary documentation that's required to show they're eligible for programs, which could include things like a disability verification, for example, for certain programs. And then finally, relating to placement, some things as kind of straightforward as support, helping to provide transportation to help people to get to appointments, with landlords, to different appointments that are to get documents ready. That's often a piece that can be really helpful to provide as well. And then finally, just following up with people that you have relationships with once they're housed, to make sure that they have continued connections to healthcare and other needed support to help, again, increase the likelihood of long-term housing stability. Next slide. So you have all heard from me plenty now. I'm really excited to turn it over now that we've kind of gone over the basics of homelessness response and coordinated entry and some of the opportunities that those two services or those two systems offer for folks working outside, and especially in the healthcare field, to connect in and help connect the folks you're working with to housing resources. So really excited to have Shelby Ferguson here with us, who's the Continuum of Care or the COC administrator for Contra Costa County Health, Housing and Homeless Services, or H3 in California. And she previously acted as the H3 Coordinated Entry System Manager. So she's got lots of great direct expertise that she'll be able to talk through and kind of ground some of the concepts that Alicia and I have been talking about in more specific community terms and practice. So I will hand it over to Shelby. Really excited to have you here, Shelby. Thanks so much for being here.
Yeah, thanks so much, Jillian. Hi, everyone. Thanks for having me. Again, my name is Shelby Ferguson. I use she, her pronouns. And like Jillian said, I am the Continuum of Care Administrator, formerly the Coordinated Entry System Manager for Contra Costa Health, Housing, and Homeless Services. It's a mouthful, so we call ourselves H3. We are a community located in Northern California. And our community is about the size of the state of Rhode Island, just to give you context of how large our community is. Next slide, please. So just to give you a little bit of background of health, housing, and homeless services, of what our mission is and our vision, we're committed to making homelessness an uncommon occurrence in our community. And we do so by integrating supportive housing, homeless services across our system. We coordinate our local homeless crisis response system across our county. And then we also work with our community partners to develop strategies to help address housing in our community. As you all probably believe too, housing and homelessness is a key determinant of health. So I'm going to be talking a little bit about that. Next slide, please. And I also want to give, before I jump into really specifics of services we offer and ways that we connect with behavioral health, just kind of a history of where our division came from, because it's kind of unique. So we actually started in the 90s, so a while ago. We started in the Employment and Human Services track. So we were a part of our local Employment and Human Services division back in 1990. And at that time, we were just homeless programs. That's all. We were pretty short-lived at that time, and then we moved over to the local housing authority. So our community has a couple housing authorities. We moved under our countywide umbrella housing authority in 1992. We didn't feel like we really fit in there. It made sense at the time because we're, a housing and homeless agency. So at the time it made sense, but it wasn't quite the right fit. So a couple years later, we actually moved under our county health department. It was the public health division at that time, which was an umbrella of our larger health department. We were there for quite a while because that's kind of the time where it was determined that, housing is a social determinant of health, and it very much fits within public health, behavioral health. In 2011, our community actually developed a behavioral health services division. So before it was just public health and, everything was under that umbrella. And then we switched over to a behavioral health division, which included alcohol and other drugs. And we were really nestled under that division. We continued to grow and expand rapidly in a couple of years. So in 2016, we actually became our own division. We found that we were so large and we really needed to be our own division. So while we're still under the umbrella of our Continuum Health Services, we are actually our own division now. And then in 2017, we added our county administrator department. But that just gives you a little context of where we came from, and that we've really been a part of health and behavioral health services for quite some time. That's really where we came from. All right, thank you. So I want to talk a little bit about how our community collaborates with behavioral health in a couple different ways. So first, and probably most importantly for us, is the way we collaborate regarding housing and housing services. So one of the two biggest ways or two biggest projects we have, one is No Place Like Home. That's actually a fairly recent project. We got that a couple years ago. That's a partnership between our county behavioral health department, as well as my department, H3, and an affordable housing developer to provide permanent supportive housing for people who meet that No Place Like Home criteria, which is, having severe and persistent mental illness. So our behavioral health partner, they provide those on-site services and support that are really behavioral health, mental health focused to the residents on site. And our job at H3 is to provide the referrals through coordinated entry. So a lot of referrals for behavioral health housing historically haven't gone through coordinated entry. It's really a new thing. So in the past couple of years, we've been able to standardize how some of those referrals are being made through coordinated entry and really build that partnership with our local behavioral health department, which has been really a great partnership and great to see. We also have a very long-standing program, Mental Health Services Act, or MHSA. We have MHSA housing in our community, as I'm sure many of your communities have. That's been a partnership between our behavioral health division, my department, H3, and other nonprofits in our community who provide housing, permanent supportive housing. And the role of behavioral health in this type of housing, they actually manage the overall program. They verify eligibility of referrals. And H3, or Health, Housing, and Homeless's role is really to provide those mental health focused case management supports. We have a licensed clinician within our department, and they provide that mental health clinical support to people who are moving into this type of housing. So they get mental health focused support. And we also provide the coordinated entry referrals for not all, but some of the MHSA units that are available in our community. So these are just a couple ways that we partner with behavioral health in relationship to housing, and just really want to highlight that it's been a really great partnership, and it's a way for us to be able to serve people with mental health conditions or behavioral health needs in our community, and something that I think is unique in coming in other communities. Next slide, please. So I also want to highlight some collaborations we have with behavioral health as far as other services, not necessarily related to housing, but things that they partner with our continuum of care. So we did a pilot program, it's a mouthful, Homeless Mentally Ill Outreach and Treatment Team, or we call it HMIOT. We piloted that program in 2019, right before the pandemic. It was just a year-long program, but it was a partnership between, again, behavioral health, my department, H3, and that added some clinical support to our outreach teams. So we have an outreach model in our community, but it doesn't usually come with that, clinical or mental health related support. It's generally peer support. So this was kind of the first time that we were able to implement that clinical support to our outreach model, and it's really informed our future models of outreach. So although we weren't able to continue on with that program, our kind of new model for outreach, when we're able to provide, get the level of funding that we need, is this type of model of outreach. It includes the peer support, but it also has a clinical component. So when our outreach workers are going out into the field, they have a clinician with them who can assess right there in the field for folks who might need that. We also partner a lot with our Healthcare for the Homeless team. I'm sure many of your communities have Healthcare for the Homeless. This is a partnership between our public health team. So we have public health and we have behavioral health. Sometimes that can be used interchangeably, but this one is a partnership between our public health team and Health, Housing, and Homeless Services, our outreach teams. And that's where we provide behavioral health in the field. So our outreach teams, our peer supports are going out into the field with our mobile outreach Healthcare for the Homeless team, and they're providing assessments, basic needs, if they need to take someone to the hospital or something like that, or if they can even provide medical care in the field, they'll do that. So that's some of the ways in which we're partnering with behavioral health and public health that aren't necessarily related to housing, but definitely really important in our community. And some other ways that we collaborate with behavioral health that aren't necessarily related to housing or services, just kind of other things. So we have a data warehouse in our community, and that's really just data sharing between our behavioral health department and our homeless system of care. So the goal of that is so we can ensure continuity of care between our clients and within providers. So we're able to access some of those medical records and information we might need on our side, the homeless services side, with that data sharing. That took a couple years to get up and running, but it's been hugely successful. So when we go into our data system, we're able to see some crucial information about the provider that someone might be working with in behavioral health. So that's been a really great addition to our system of care. I also want to highlight, Jillian touched on this a little bit, housing placement meetings. So in our community, in coordinated entry, we have housing placement meetings when we have units that become available, and we're going to, match and select people for those units. So we'll call a housing placement meeting through coordinated entry with our providers of people at the top of our priority list. And that also includes people in public health and behavioral health. So we have a whole person care pilot. We call it Community Connect in our community. And we often have a lot of Community Connect workers, which might be social workers, public health nurses, substance use counselors, things like that. We invite them to the table to come to these housing placement meetings because they often have really crucial information about the participants that we're going to be discussing. So we go through a standardized screening tool, and they have knowledge and expertise about, some of the behavioral health needs that the person might have that maybe, our outreach teams, our peer specialists don't have, that level of detail or knowledge. And they often have a really good relationship with the person that we might be talking about or prioritizing for this particular unit. So we do make a really conscious effort in coordinated entry to include people in behavioral health providers, things like that. We also have a governing board, which is our Council on Homelessness, is what we call it in our community. We have about 20 seats on that council, and that really governs our homeless system of care. One of those seats we have dedicated to behavioral health because we see, the importance of that relationship, that behavioral health is such a big piece of the puzzle for housing and homeless services. So we have a dedicated seat for a behavioral health person. It changes year after year, but always somebody within our behavioral health department. And then I wanted to touch on how behavioral health can connect to coordinated entry and vice versa, how that works in our community. So behavioral health really connects to our coordinated entry system, just like anyone else would. We have 3 access points in our community for coordinated entry. We have a phone line, the 211 line. We have our mobile outreach teams, which are peer supports that are going out into the field and meeting people where they're at. And then our third access point are our brick and mortar sites. Those are our drop-in centers. We call them care centers. So those are the 3 ways that people can access our coordinated entry system. And we often do presentations with our behavioral health partners to talk about those access points and make sure that they're educating people that they're serving on how they can access coordinated entry, how they can access our homeless system of care, because we do know that it's complicated to navigate. So we often do trainings, cross trainings, but we often do trainings to make sure that those providers know how to access our system. And then at coordinated entry, how we access the behavioral health system is we have a county-run access line for behavioral health. So if we encounter a participant in coordinated entry who might need access to behavioral health, maybe they need to get reconnected or they're interested in going to a clinic, they can call the county-run access line with one of our providers, and they'll walk them through that process of how to get connected. But again, we definitely want to reiterate that we have our behavioral health providers access our system the same way that anyone else would. And same thing with behavioral health. We access their system just like anyone else would. We try to make a conscious effort of not making, kind of these side doors or, these exceptions, because then it gets a little bit tricky. But yeah. And then I wanted to touch on, I think this is important to talk about how we in homeless services serve people with complex behavioral health needs, because it is a challenge and it is something that comes up often. So some of the challenges that we experience is just the sheer number of people who have behavioral health needs. That number is really growing by the day, unfortunately. We also don't always have funding that aligns to support people with mental health focus or clinical case management. Often our case management is just really more generic of maybe helping people with those basic needs, but we don't often get funding that helps folks with mental health specific case management. We also lack mobile teams. While yes, we have outreach teams, we have 14 of those in our county, which does sound like a lot. They aren't, behavioral health focused. So we lack those behavioral health focused teams. Although I did mention we are trying to incorporate more clinicians within our outreach team, that can be a challenge. And like I mentioned, our programs aren't always specific to serve those people with behavioral health challenges. So some of our programs, such as our brick and mortar drop-in centers, they're not equipped with clinical capacity to help people who might be experiencing a behavioral health crisis. So that can often be a challenge. And we also just have it's a mobile behavioral health team in our community, and it's just one team to serve our entire community. So it is slim for us. And then I think just one of the biggest realities is there's still stigma around serving people with behavioral health. We see that in our community a lot, oftentimes with, private landlords or outside landlords, people that we're trying to lease up with outside of our continuum of care. We still struggle with some of that stigma. So just trying to do some education around that. Some of the strategies that we've come up with to combat some of these challenges is, like I had mentioned before, with our MHSA housing, we have a licensed behavioral health clinician who provides the case management for those people in those programs. We also actually added about 4 or 5 years ago behavioral health interns. So we have about 5 or 6 usually each year MFT interns who really work with this licensed clinician to go out and not just serve people in MHSA housing, but also in other areas of our system. Perhaps they're in a different permanent supportive housing program that's not necessarily connected to MHSA or behavioral health in any way. They can provide some mental health focused support that really helps participants when not all of our permanent supportive housing programs have that level of support of wraparound services. Like I mentioned, we're also adding clinical capacity to our outreach team. So when funding is available, we're calling it our Outreach Plus model, where it's 2 peer specialists and we're adding 1 clinician to go out into the field and be able to provide those assessments to folks. That's been a really big add-on in our community. We also have partnered with behavioral health for quite a few years now, actually, to co-locate in shelters. So our shelters are staffed with shelter attendants and case managers, maybe income specialists, but we also often have a clinician who's on site in part of our behavioral health division. So we have a collaboration with behavioral health so they can provide on-site assessments, things like that. They also participate in case conferences for those shelters. So again, making sure that they're part of treatment planning, case conferencing, housing placement meetings has been a really big deal in our community and a huge add-on. And we also have medical respite. So it's small, but we have about 10 beds specifically for people who might need medical respite temporarily before they move back into housing. So I wanted to touch on how we in our community incorporate people with lived experience. So like many of your communities, this is a big deal right now, and we're really trying to find ways wherever we can to incorporate more people with lived experience. So we have actually quite a few different ways that we do this. We have what's called a SPIRIT program, or a service provider individualized recovery intensive training. That's also a mouthful. That program gives people a certificate and helps them become basically a peer support. So a lot of those people who graduate from that program, they're people with lived experience. They come to work for our outreach team. So not everybody in our outreach team is a graduate of that SPIRIT program, but we do get quite a few people who graduated from that program and got that peer support certificate. And in general, most people in our outreach model, they are a peer support. So they have some lived experience with either homelessness, mental health, substance use, or all of the above. So we do try to hire people who have that lived experience. So when they're going out in the field and meeting people, in a really vulnerable, unsheltered place, that they have that life experience, that really assists them with their work. We also have 3 seats on our governing board, our Council on Homelessness, for what we call lived experience advisors. So we had 1 seat before. We added 2 extra seats this year. So we were able to make room for a 2nd seat, and then we converted one of our seats that was for public safety. We had a couple public safety seats, and we felt that, adding or converting that to a lived experience seat was much more valuable to our community than having multiple public safety seats. So we have made that change, and we have about 20 people. So it's 3 people out of 20, but we are always looking to add more seats for people with lived experience. We also have a county-run, what we call Youth Advisory Council, or our YAC. That's made up of a very small group of youth who have gone through our county-run youth services, so maybe our youth shelter or our youth transitional program. And they go around and they do presentations, often on youth or transition age youth experiencing homelessness, that experience. They do advocacy events. They participate in our council. They give monthly updates. And then we just started a shelter resident council. So a couple of our county-run shelters are starting a resident council where they're going to be bringing people to the table to talk about shelter policies and how they might make that more person-centered, client-centered. So that's a new addition to our community just this year in the last couple months. We're really excited to be able to offer that. And then one of our nonprofits, they run a resident empowerment program, or their REP program, where they compensate the people in their programs, but they select a couple people who might want to volunteer for this. And they do kind of a similar thing to our YAC. They go around, do advocacy. They do a lot of training and education to affordable housing developers. They do lobbying. They do quite a bit of things. It's really cool. And they also participate in our Council on Homelessness meetings. And then just want to touch on very briefly that we're doing some equity work. So we had some equity work with our consultant, C4 Innovations, and other technical assistance where we're looking to incorporate more people with lived experience in various places within our system of care. And I didn't touch on this, but I know that it will be a huge topic, like how do you compensate people with lived experience? So we're talking about, having people with lived experience in these different pieces of our system, but really what's most important is talking about how do we compensate them for their time, their knowledge, their expertise. So in our community, we're able to provide an hourly stipend for those 3 council seats for the people, the lived experience advisors on our governing board. So we're able to offer $23 an hour for a stipend. We have planning grants and things because we're a government agency, so it doesn't work for everyone, but if you are able to provide a stipend, it's super important that you do so. We also, if we're able to provide gift cards when people provide community input. So when we're asking for, surveys, or we ask for input in various meetings or committees, that we provide gift cards and we try to ask people where they prefer. So recently we've been giving a lot of gas gift cards because that's what's most interesting now since gas prices are so high. Something we've talked about in our community is considering how that stipend or income from this compensating people for their time might impact people's benefits. So we try to be careful for folks who are on fixed incomes to not provide too much compensation or hours, because that can make their benefits go down. So we have talked quite a bit about that. We provide food, when we do in-person events, which isn't often at this point, but when we did, and hopefully when we go back to doing that more, we provide food as well as transportation if they are in person. So we can provide Lyft, Uber, things like that to get people where they need to be if we're doing focus groups or meetings or what have you. And that is all for my presentation. I'll pass it back to, I don't know who it is. Alicia?
Yeah. Thank you so much, Shelby. And thank you so much. That was such an incredible presentation. We are going to launch into some questions now, but just really wanted to recognize that so much of what you've talked about, Shelby, has really resonated with the people on the call. In the chat, we've seen just a lot of support and interest for the work that you've done. So we have some questions. Shelby, if you have answers, if you would like to jump in on any of these, Jillian and I can also share our insights and our experiences as well. Shelby, I think this one was particularly for you. There were questions about the screening tools that you're using in your community. I think both for coordinated entry for your standardized assessment tool, as well as the screening tools you're using for behavioral health needs of unhoused individuals.
Sorry, I gotta get myself off mute. Yeah, that's a great question. We get that question a lot. So we have a couple different tools that I think we're talking about here. So we have what we call a triage tool when people are entering our coordinated entry system. And that is really to determine, if people are parts of subpopulations that might need specialized services, if there's ways that we can divert them from our system, if they have any, special needs, if they're families, if they have disabilities, things like that. So we're screening for that up front through coordinated entry. The other piece that I did touch on was those screening tools when we're talking about housing placement. So when we have those housing placement committees that people are probably more interested in, that screening tool, we have a couple different ones, but the one we use most is our permanent supportive housing screening tool. That was actually developed with our providers. So it was a partnership with our coordinated entry team and our providers, which did include, public health, behavioral health providers, on developing those questions. One of the questions is, what is this person's ability to live independently? And if they can't live independently, what supports would they need? And sometimes that's IHSS work. Sometimes that's they need to be connected to a therapist or a behavioral health clinic. And we also ask, do they have any current behavioral health challenges that are unaddressed, and are there ways that we can address them? So our community definitely took feedback from our providers on specific questions we could ask to get at those behavioral health needs.
Thank you so much, Shelby. I wanted to share it. There's a question, but there's also kind of an information here. So someone shared that at a meeting last week, a presenter described coordinate entry as an airport where there are a lot of potential passengers, but almost no planes. No matter how great the airport is or how many improvements are made, without more planes, in terms of housing, the odds of going anywhere are slim. So first of all, I just wanted to share that metaphor. And the question that this person has is, are people being trained to make that clear to people when they are coming into the system? And it sounds like there's another question here about, like, how do you navigate that the kind of disparity between what's available, between the supply and the demand?
Yeah, that's a great question. That's $1 million question. I really appreciate that metaphor, but yeah, that's a reality definitely in our community with the lack of affordable housing in California is huge, but we really try to make sure that we're training our providers to be realistic and upfront about what might be available to that person. So we do try to do a lot of trainings around that and coaching how providers can talk to participants when they're doing assessments. So they're not setting them up thinking that, you might get this resource when in fact, just like this person said, most people aren't going to get that permanent supportive housing resource. We don't have that much. Another thing in our community that we're really trying to implement, I'm sure a lot of your communities have been implementing, is we call it rapid resolution. Some communities call it housing problem solving. But basically, we're trying to do a couple things: divert people from entering our system in the first place. So we're getting a lot of funding and resources for prevention work, so people aren't even coming into our system, so we don't have to do that assessment and have them come into our shelter when we know we don't have resources. And the other piece of it is we're trying to rapidly exit people who are already in our system. So we do train our providers on problem solving. So it's like creative conversations you're having with people when you're working with them of what other resources they might be able to tap into. So for our community, that's really huge because we don't have enough. So if you have friends or family that you can stay with, when was the last time you talked to your sister or your grandma? Is that a relationship that we can work on mending? What would it take to get you there? So those are some of the creative conversations and questions that we train our providers to ask, not just at that initial assessment, but throughout their work with people, because we often find, when the person first comes in, they're in crisis mode and they're not able to think about those things. But maybe a few weeks or even a few months down the line, where things have stabilized a little bit in shelter, let's say, they're able to have that conversation and, I actually really would like to reconnect with my sister. And we have case managers who can help people have those conversations, some of that conflict mediation. We also have a flexible pool of money in our community where we're able to send people home. Some people call that homeward bound, but we're able to get people bus tickets, train tickets, things that they might need to reunite with family, and making sure that that's a plausible placement for that person.
Thanks, Shelby. I have a follow-up question from, we have a few questions that could be related a lot to what you just answered, but one that just popped up that I think is a good one because other folks have asked about data too is with respect to that problem solving or more like prevention work that you're doing, are you tracking that in HMIS somehow? And if not, how are you tracking to kind of, monitor what work is going into that and what maybe your outcomes might be?
Yeah, that's a great question and something we're kind of just getting started actually. So we're upping our prevention programs, and not all of them are in our homeless management and information system or HMIS, our data system, but we have several that are, and we're treating it just like we treat any other program. So they have a standard intake that asks, those standard questions that any of our other programs would ask in a standard intake. Same with the exit. It's a standard exit, and then they're tracking the services. I think the biggest thing for us for prevention as far as tracking is we're trying to track follow-up. So we're trying to make sure that after, 30 days, 60 days, 90 days, that person is still safely housed. And we're building right now some follow-up mechanisms in our data system to make sure that we can track that properly. Because I think what some of these people are getting at is there hasn't been great data on prevention programs, because a lot of the funding that we've gotten hasn't been for prevention, or it hasn't been a push for prevention resources. But now that there's such a need for that, I think we're going to see a lot more data in our system at least.
Thanks, Shelby. And one other quick follow-up on that, especially relating to the fact that at least through HUD, like COC funding, I don't know if that's just what you're talking about, but not a lot of that is available for prevention, if any. So I'm wondering too, to the extent you have been involving maybe additional partners, especially like mainstream providers outside of the COC, for example, or folks who aren't usually considered kind of COC members in those problem solving, either conversation or the planning for how it works on either the diversion or like relating to actual resources that might be available, or just sort of strategizing about how that problem solving or diversion work could be improved or implemented.
Yeah, we're definitely trying to do that. We do try to train not just our internal COC providers, but other providers who might be interested in housing problem solving. So we do an annual continuum of care training on housing problem solving, and anyone can attend that training. And we often get outside providers. We also have had some, outside of our system providers who have gotten some of those non-traditional prevention funds. And, they've never done prevention. They're not really sure how to go about doing it or how to go about housing problem solving. So one of our agencies that does prevention work or rapid resolution work really well, we had them train that provider for a couple months on, how do you screen? How do you properly address the people's needs that are coming in? So we've had a couple instances where we've been able to train outside providers.
Great. Thanks, Shelby. So this is a kind of category of question that's a little bit harder to answer. And so Shelby, I don't think we expect you to have the answers because some of this will vary so much by program and community. But if you had thoughts on this, I think some folks would appreciate it. And Alicia, maybe you and I can try to think about some ways to supplement as well. But basically we had a couple different questions come from folks who are essentially being or feeling like they're not able to participate in coordinated entry despite trying to. So either they're not able to access HMIS despite working directly with folks and having trained and submitting referrals. Some folks are having a difficult time or not being allowed to submit referrals or attend case conferencing. So it seems like we've gotten a couple folks, and I'm not sure which communities they're in, so I don't want to assume or ask, but if you have guidance on maybe from some of your experience of similar situations where folks were wanting to participate, but maybe there were some either challenges or barriers, or if you could maybe shed some light on what some of those reasons might be and maybe some potential suggestions for how to navigate that space.
Yeah, that's very real. At least in our community, I mean, I've been the coordinated entry manager for a few years. We also have a couple coordinated entry specialists. we make a concerted effort to really involve all of our partners. So we have, an open door policy with them. So we have a lot of behavioral health partners that don't know about the coordinated entry system or don't know how to access it. They'll reach out to me directly and say, hey, can I be involved in this? Or could I make a referral for this? I try to do my best to redirect them to how the process works, but always invite them to the table. So I would definitely recommend, if you don't already, establishing a relationship with your coordinated entry team, if you have one. It depends on your community and your size, but if you have a coordinated entry manager or someone who manages your coordinated entry system, develop a relationship with them. See what meetings you might be able to attend. Some meetings, are really specific for certain providers. And it really depends on the community. Ours, we're really open to adding other providers in our HMIS system. So we actually have some behavioral health providers who have access to our HMIS system. They're not able to enter data in that way, but they can see what's being entered, and that's been a huge value add for us. So if you have, if you're able to talk to your continuum of care and whoever's managing your data system, and see if that's a potential for you to, we call it read-only access. If you're able to get read-only access, that would even be a start.
Thanks, Shelby. I think at least one person mentioned, it's interesting you ended with that read-only, because at least one person mentioned like not even able to access read-only. But so I think like you mentioned this, that it depends so much on the community and also like existing relationship dynamics between programs and individuals. And so I don't want to be dismissive of the challenges people are experiencing, for sure. And I also don't feel like I'm in a position to assume like what is always going on at every level. So the only things I would add is just, in addition to everything Shelby just suggested, I think to the extent you can, and I know this can be fraught, and I hope no one's rolling their eyes at this, because like they've tried these things and it's feeling like I'm, telling you to keep doing what you've been doing. But I think to the extent you could try to get to the bottom of like what the impediment is. Like if you're being told you can't access it this way or that way or this way, or there are rules in the way, I think trying to ask follow-up questions that are framed at like sharing where you're coming from. Like, I'm working with clients and I don't feel like I'm able to get them access to the systems that you have in place, or I think I have this experience and expertise that could really be useful for improving the system. And so I'm trying to understand more like what all are the reasons, or like what's behind the fact that I can't get access in X, Y, or Z way can sometimes be useful. And I think I know it's easier said than done, and also in some situations will work better than others. But that's the only thing I would add, is that trying to get on the same like page language wise and drilling down, because sometimes it's just a matter of people are a little bit worried about funding requirements and don't want to accidentally be out of compliance with something. And so the easier thing to do is just say the way we have it set up is the way it has to be. And so I think some follow-up questions or just additional conversations can sometimes help reveal like what's going on, and that can give you some new avenues to maybe address it.
I would also just like to kind of address that. I think sometimes one area in particular where we see like concern about sharing is potentially sharing of information that could be HIPAA protected. And we also see concerns around sharing information with law enforcement, that because there are concerns about it being used in a punitive way, and that I think helping to break down those concerns and some of the things that we might see common themes around there. I think there's some myth busting that can be done, and there are some communities out there that are forming those really strong relationships. Obviously we're talking today about forming those relationships with health and behavioral health. There are also some communities, and you may be able to search and find some case studies around those partnerships with like sheriff's departments, Department of Justice. So I think being able to pull forward that this is happening in some places, and there are agreements, there are memorandums of understanding, there are protections in place, so that those partnerships are really around supporting the client, and that's the goal. That's the reason why we're partnering to begin with. So it's definitely not easy. I think that all three of us are, it's really trying to keep coming to the table and keep that conversation going in a way that's going to best serve your clients. And, we really wish you, we wish you all the best with that. And we hope that we can help provide some resources on this call, like some talking points, maybe some ideas of how to support you in those efforts. So.
All right, this is less of a follow-up to that and bringing it down a little bit more concretely, but we have a couple questions relating to this, but essentially I think this is Shelby relating to one of your earlier slides. And so the question is about, with behavioral health managing or participating in the management of supportive housing, how do you balance that with wanting it to be a voluntary system that allows residents to refuse behavioral health services? And so there's a similar question about how do things work when folks are declining additional services beyond housing, even if there's a perception by folks working with them that they might need additional services?
That's a great question. I was just talking about this exact thing today. This happens a lot, actually, because like this person is clearly alluding to, there's some differences of opinion about services and what that looks like. We're operating from a housing first model where all services are voluntary. So we do run into this. And actually in our No Place Like Home program, where we're working with our behavioral health provider, they contract to do the supportive services. They do have an idea that, everybody has to participate in the services, and the people who are going into those units need to be high service needs and utilize the services frequently. So we had a lot of really tough conversations with our behavioral health department of, that's not how we operate. And if the referrals are coming from the coordinated entry system, we have to operate from a housing first model and be low barrier. So we did a lot of education around where we're coming from as far as all services should be voluntary. And as long as they meet that initial eligibility, then we're good. We want to be able to offer those supports to people at multiple times, throughout their stay in the program, but we don't require it. So we did have some really tough conversations about that, and we don't always see eye to eye on that. And I don't necessarily know if we even came to an agreement where we agree on that, but we at least agree to operate in a way that's housing first and not forcing services on folks.
Thanks, Shelby. One other question that's come in is someone sharing that one of the issues I see with behavioral health and housing is that many housing supports as part of supportive housing programs are geared towards people with more severe mental illness. And so there are fewer options for less intensive interventions for folks that are housed but need some level of support. And so this person is in particular sharing that they're in a program that they outgrew a long time ago, but there's not a place to move on to. And so just sharing, it'd be great if there was a way for me to, this is from the person asking the question, to transition and give someone else who needs this higher level of support this opportunity. So I wonder if you could speak to any kind of move on or other programs, and especially to the extent that you have behavioral health programs as partners and kind of deciding how to assess the level of need people have and how to kind of right size programs as a result of that.
Yeah, well, that's a great question. So in our community, we attempted to establish a moving on program in 2015. Didn't end up getting the funding for it. So we've had it kind of as a back burner program, but we haven't been able to implement it. Just this year, or actually 2021, was the first time we were able to do moving on in our community with those emergency housing vouchers. So you've probably heard of those, probably heard people talk about them extensively, but our community chose, like many communities, one of our priority groups to be people who are in that exact situation. They're in permanent supportive housing. They no longer need the supportive services. They only need a permanent rental subsidy, and they're ready to move on. So we prioritize that. We were able to move upwards of 50 households from permanent supportive housing into a voucher program where there's no services attached, like this person's saying. So you have the permanent subsidy, you don't have the permanent services because you don't need it. But the reality is we don't necessarily have set program in place to continue moving on. I'm hoping in the coming years we'll have more situations like this voucher program and other areas where we're able to implement more moving on strategies. And then as far as behavioral health is concerned, we haven't really engaged with behavioral health in that way yet because we haven't had any place to move people onto. So that's a really big struggle in our community. So we definitely don't have all the answers yet. We're really getting started on that strategy.
Yeah. Thanks, Shelby. The only thing I would add to that is if folks are interested in learning more about that, I mentioned it, then Shelby referenced like the phrase move on, which is often what these programs are called for folks who are, for example, have been in permanent supportive housing, which is a higher intensity case like supportive services matched with housing, and it's a permanent resource. And so when folks like the person who submitted this question feel like that level of service is no longer needed, there's sometimes programs set up to help folks with that. But if you're interested in more information, like Googling the phrase move on programs is a good way. You can find lots of resources and some examples of those. But the other piece I would just mention, which I'm kind of trying to wrap us up to, because we do have a lot more questions, and I apologize to folks whose questions we didn't get to. Some of them, it's because they are really big questions that would require about 30 minutes to answer. So, but a lot of them do relate to, or could be answered in part by the idea that when your coordinated entry system is not in your experience, like is not working for the clients that you're working for, or you feel like there are improvements that could be made or should be made, one really critical piece is always not just involving yourself in the way that like Shelby was outlining in different COC meetings or trying to build relationships and the other ways we've built out, but also the more that you can kind of keep track of information about the people that you're trying to serve or that you're seeing are kind of being left out or not able to be served by this system, the more information you have on that, and I don't mean like sharing personal information about clients, but just at the aggregate level as well, the more helpful it will be when you're trying to have conversations with the COC about these are the things that I think that the current operations of our coordinated entry system are not serving this population of people well, or this resource is still needed. And again, that's another thing that's like much easier said than done is, well, collect data about it and you can kind of make your case for which pieces are missing, but that is just like a required piece of keeping an eye on how things are going and which pieces are, where there are opportunities to improve and better serve different, individuals and households, and kind of having that information in mind when you're having these conversations can be really helpful and can help inform like the annual or the ongoing process of sort of monitoring how coordinated entry is operating and making improvements and adjustments. With that, I will say, again, apologies to folks whose questions we didn't get to. Really appreciate how engaged everyone was in asking a lot of questions. I know coordinated entry is a great concept and great idea, but I know the actual implementation can be really frustrating, and especially because there are a lack of resources, it can be really difficult to square like the people that you're working with how the system is set up. So really just want to say, we appreciate all the work that you all are doing in your communities and know how difficult it can be sometimes, but appreciate that you all are continuing to, ask these questions and talk with one another about how to make improvements for the people that you're working with. And thank you again so much to Shelby for your presentation and answering all these questions. Really appreciate you being here to share your insight. And I know folks were really excited about you sharing your email and your slides, so you might get some follow-up questions or connections from folks as well. So we have on the screen, just to close out, we want to give folks a few minutes. If you could, there's a link in the chat, and also, if you want to scan this QR code if you're fancier than I am and know how to do that well. We'd love to hear from folks. What's one thing you'll take into your work based on what was shared today? It's always really great to hear from you. We have such great participation in these webinars, and it's really great to see what resonated with folks, what was useful to people. We use it to, inform future sessions as well. So anything that you want to share, and you can see what folks are putting in there, if you'll take a moment. And then in just a sec, we'll also share the link to the evaluation, so you can evaluate this, complete the evaluation, and download your certificate. That link is in the chat as well. You can go ahead and pull that now. I think so, yeah. If people want to continue to, please continue to share in the Menti what you're taking away. Make sure you get that evaluation and download the certificate. The link to where you can access the slides and the recording has been shared. And again, we really appreciate everyone's participation. Oh, thanks, Alicia. Here's where you can get the, if you didn't pull it from the chat, here's the code for getting the evaluation and certificate. And again, thank you all so much for being here. We look forward to seeing you on the next session, which is August 2nd, where we'll be closing out this session and looking at actually providing behavioral health assessments and behavioral health services in encampments and other unsheltered environments. So thanks again, everyone, so much. See you next time.